Great. Hello and welcome to this ARMA webinar on what everyone working with back pain needs to know about Cauda equina syndrome. My name's Sue Brown and I'm the Chief Executive of the Arthritis and Musculoskeletal Alliance, ARMA. We're an umbrella body that brings together patient and professional groups to work for better health services for people with musculoskeletal conditions. ARMA webinars are free to access thanks to the support of our partners, and we're delighted that the Musculoskeletal Association of Chartered Physiotherapists, MACP, are supporting this webinar. The numbers registering for this webinar are far in excess of any other that we've ever delivered, which shows what an important issue this is. And it's great to have Chris Mercer and Laura Finucane to present today. Both of our speakers are honorary fellows of the MACP. Both have a special interest in serious pathology of the spine, and between them they work, teach, research and present nationally and internationally on the subject. So we are in good hands. Chris and Laura, over to you.
Thank you very much, Sue. So I'm going to share my screen. So thanks very much for joining us on this webinar. We realise that there's a really quite a lot of noise around Cauda equina syndrome, and certainly over the last few years there's been a huge amount of information. So what we're going to try and do in this presentation is to pull that all together and kind of make some sense around it. So but before I start that, what I want to do is just to acknowledge Sue Greenhouse, who has done an awful lot of work within Cauda equina syndrome over the years, and in fact she was honoured with an OBE this year, which is fantastic, really around her work, and Chris and I have been really privileged to work with Sue very closely on Cauda equina syndrome and all things serious pathology. And in 2017 we were asked to increase the awareness of Cauda equina syndrome by the CSP because there was a huge amount of litigation. So we did a video. We presented nationally and internationally, and we wrote a paper in the masterclass paper in Musculoskeletal Science and Practice. We recognise that there is a huge amount of anxiety around diagnosing and managing Cauda equina syndrome. So we're going to hope that this presentation will hopefully clarify some of the issues and concerns that you may have. And what we will do is we will update you on some of the guidance likely to change in the next month or so following a Cauda equina study day back in December. So are these items basically. The definition, we know that this is really challenging. There's huge numbers of definitions out there. We equally know that early diagnosis is critical for these patients because we know that they do better, but that is really challenging in itself. We're going to talk about assessment. We're going to talk about the pros and cons of assessment and mostly the evidence around the objective assessment. We're going to talk about medico-legal. We know that Cauda equina is associated with disproportionately high levels of litigation and successful claims against the NHS when you compare it with other conditions. And it's often associated with delays in diagnosis and intervention. And we'll talk about some of the research trials out there. What's really important about this presentation is that actually it's about the patient, and we know that it has life-changing consequences. Lots of patients will have really very poor outcomes. They have ongoing treatment for sexual dysfunction, self-catheterization in some cases, and even patients are manually evacuating their bowels. We know that there's a huge psychosocial issue when people are left with these issues, and they very rarely go back to the same job or work. So it has huge effects.
Can I just stop you a second? There's quite a lot of feedback that I'm hearing. I'm not sure if that's coming from you or from Chris, but I think somebody might have papers near their microphone or something.
Okay.
Sorry.
Okay, no worries. Let's just keep going and see. Just let me know if that's better. Is that better, Sue? Okay, so what we do know is that we know quite a lot around the physical consequences of Cauda equina syndrome, but actually there's very little known about the psychosocial issues that these patients actually end up with. So, a paper by Hall and Jones really demonstrates that these people feel very abandoned when they have these symptoms. And what people feel is that they don't, because they're not obvious, they are often hidden, that nobody really knows how awful it is for these patients. And some of you may have listened to Chris's podcast with Janine, who's a cauda equina sufferer, and it's very frank.
Laura, we're still getting a lot of feedback here. I'm not sure what's causing it.
Yeah, I'm not sure either, Sue. I'm not by a mic, so I'll try and
try again.
Okay, so what I was trying to say was that a podcast with Chris and Janine was a really frank conversation around how she's dealing with those symptoms, and there's very little information for patients who actually end up with cauda equina syndrome going forward. So I think it's really important that we understand those consequences for patients. So if we just consider the anatomy of the cauda equina, we know that the cauda equina is made up of 20 nerve roots that descend almost vertically below the conus and the L1. It provides innervation to the lower limbs, the sphincter, sensory innervation to the saddle area, and parasympathetic innervation to the bladder and distal bowel. It's an incredibly vulnerable structure, and if you've ever seen it, it looks a little bit like vermicelli. So it's quite surprising we don't get into more difficulty. And cauda equina is the consequence of the nerves being compressed at that level. And it's often the result of a prolapsed disc. That's the most common cause. But we do know that there are other ways of it being damaged through things like metastatic spinal cord compression or even spinal stenosis. In the literature, there's really helpful characteristics and features around cauda equina syndrome, which are these 5 particular characteristics. And patients might report any of the following of these with, when they present with cauda equina syndrome. They may have bladder dysfunction, and this is often the most commonly reported symptom, and it can range from increased frequency, difficulty in micturition, change in stream, incontinence, and retention. They might report bowel dysfunction, which again may include incontinence, the inability to control motions, and the inability to feel when the bowel is full, which can consequently cause overflow. They may describe reduced saddle sensation, sensation reduced in the perineum and saddle region. They might describe pins and needles and numbness around that area. We know that sexual function is not really widely mentioned in the literature, but it's incredibly important to ask your patients about sexual function, because this could be the only aspect that is affected. So for men, we want to know, can they still get an erection? For women, if they're sexually active, can they feel when they're having intercourse? We know that the clinical diagnosis of cauda equina is, there's no really broadly accepted definitive diagnostic criteria. There are 17 different definitions of cauda equina, and we know that the signs and symptoms can be really subtle and vague, and they can vary in intensity and evolution. And there is not a progressive in nature, so they could start at any point with these symptoms. So if we look at the definition, Fraser looked at 105 papers, and essentially there was no agreement particularly around what that definition should look like. But the majority view was that bladder and sensory dysfunction was really one of the key areas for that definition. But we actually really like this as a definition. This is from BASS, the British Association of Spinal Surgeons, and basically what they quote is that patients presenting with acute back pain and or leg pain with a suggestion of a disturbance of their bladder or bowel function or saddle and sensory disturbance should be suspected of having cauda equina syndrome. And in the absence of any reliable signs and symptoms, then we should be doing an MRI scan in an emergency. And if you don't do that, then you need to describe why you're not doing that. But we also know that the subjective history is absolutely key to early diagnosis, and that requires really expert questioning, clarity and context of information when you're asking your patients about cauda equina. We know that in terms of the national pathway, basically what it describes is that we should refer patients who are suspected of cauda equina in an emergency for an on the same day MRI and a surgical opinion. So that's really, really important. But we know that a majority of these patients will not have Cauda equina syndrome. So a paper by Woods et al. Really showed that 90% had a negative Cauda equina, with only 10% being positive. What's quite interesting is that a paper which came out this week, and I cannot pronounce this name, Horowitz-Sauer. Basically, what they showed in a systematic review was that 81% of patients with Cauda equina syndrome did not have Cauda equina syndrome. But I think the really important thing here is that 1 in 5 did have Cauda equina syndrome. So that's quite significant. And I think if you look at other pathologies, that really is has quite an impact for us. These are really helpful groupings of Cauda equina syndrome. So we have four groups, the first being suspected, then incomplete, retention, then complete. What we know is that in this category, so in the retention and complete Cauda equina syndrome, these patients have lost complete control of their bladder and bowel. And so treatment is really hard at this point. What's important for us is that we actually have some influence in these top two. So where patients have suspected Cauda equina, or if they have incomplete Cauda equina. So if they've got incomplete Cauda equina, they still have control of their bladder and bowel, which is really, really important. We can make a huge difference in these first two categories. We know that the 3 factors determine outcome, and that is the degree of neurological deficit, the duration of that compression, and the speed of onset of the lesion. So the worse the deficit is, the longer the compression and the more rapid the onset means that their outcome is going to be much worse. I'm going to hand you over to Chris.
Thanks, Laura. So I'm going to refer to the first of those categories, the Cauda equina suspected, and you'll have seen on there it was talking about bilateral radicular pain. And a lot of the work we've done over the last year has come out of a white paper that was produced by Connect Health last year, in pretty much this time last year. And what this white paper came about from was from some legal claims that had been made against Connect Health relating to Cauda equina compression and patients who presented with bilateral sciatic symptoms. So in response to that, this white paper suggestion from Graham Wilkes and the team at Connect was that patients with bilateral sciatic symptoms needed urgent same-day MRI scanning. And this white paper came out the day before Laura and I were teaching on a red flags masqueraders course with Sue. And we had a discussion amongst ourselves and with the course participants, and felt that whilst we completely understood this response from Connect, that actually in the clinical situation, a more reasoned and nuanced response would be needed. Next slide, Laura, please. So some of you may have seen this or may not. This was a start of a discussion. So Laura, myself, and Sue put together a reasoned view of bilateral leg pain and sciatic symptoms and related that to the degree of neurological deficit, plus or minus the addition of other Cauda equina symptoms or signs, and felt that a more nuanced approach to bilateral sciatic symptoms would be useful. Next slide, please, Laura. So as a result of that, we foolishly suggested that we get involved in some work and maybe get together a group of professionals who are interested in Cauda equina and have a study day. But before we did that, we met up with the National Low Back Pain Pathway Clinical Network. This is a group of multidisciplinary professionals who have previously developed a pathway for the management of radicular pain. And part of that management document is around Cauda equina. So what the discussions were with the back pain pathway were that we agreed that unilateral back pain progressing to bilateral leg pain is concerning, but doesn't require emergency scanning, but may need scanning. But in isolation, bilateral leg pain was not necessarily a red flag for Cauda equina, and that patients with bilateral leg pain should always be safety netted. And we'll talk a bit more about what type of safety netting later on. We also talked about the time factor, because as we know, and as Laura's alluded to, a lot of these patients, the symptoms evolve over time and they fluctuate. And it would be very rare for us to see a patient who turned up that morning who'd suddenly gone into retention, or who suddenly developed urinary or bowel symptoms or saddle sensation symptoms. And often their symptoms have fluctuated over a period of weeks or months. So what we talked about was, if patients had had symptoms for more than 4 weeks, then it would be reasonable for them not to need an emergency scan, but to have an urgent scan. So we just kind of divided the timelines up between emergency and urgent scan. This table adds a bit more detail into that. So on the left-hand side, we've got the presentation. On the right-hand side, what we've got is what the recommendations will be. And these recommendations will be coming out with the National Low Back Pain Pathway changes that are being updated at the end of March this year. So we're talking about bilateral leg pain with any cauda equina symptoms. Patient needs an emergency referral. That's a no-brainer. So I think we'd all agree on that. If a patient presented with bilateral leg pain with abnormal neurology but no other cauda equina symptoms, then we would suggest an urgent referral. And the management depends on the degree of motor loss particularly. And if patients have motor power of less than 3 out of 5 or significantly deteriorated motor power, then those patients should be scanned within the week. And then follow your local pathway, and obviously safety net the patient around further cauda equina symptoms. If they have bilateral leg pain but with normal neurology, maybe have some positive neurodynamic tests such as slump test or straight leg raise test, but no other cauda equina symptoms, then patients should be treated as per the radicular pain pathway and have a routine MRI scan if their symptoms are particularly troublesome or not improving with treatment. And again, safety net the patient. You'll see that safety netting is a common theme as we talk through. And the last category, sorry Laura, can you go back one? Bilateral leg pain with normal neurology, normal neurodynamic tests and no cauda equina symptoms other than the bilateral leg pain, then treat as per radicular pain pathway and safety net the patient. Okay, so we've got some clearer definition, which we're hoping is going to be helpful for clinicians in managing these patients. We also talked about assessment for cauda equina, and it's very clear that the vast majority of the information, the valid and reliable information, is gathered in the subjective. And that's been shown through lots of studies. And what's also been shown is the physical tests have very limited validity and reliability. However, the emphasis in terms of diagnosis is still very much on the physical tests. So that's part of the message we're trying to change, in that we need to take a careful history and use that to guide our management of these patients. So one of the big questions that we always get when we teach, and we always get when we talk to clinicians, or if we're referring a patient on to A&E or to orthopedics or whatever your pathway is what's their anal tone like? And this causes no end of issues for us and for the patient. It's an invasive and very personal test. And what we really want to know is it any good? Does it help us in the diagnosis of cauda equina syndrome? And this paper by Gooding et al. Is a nice paper that looked at around 60 patients and very clearly found that digital rectal examination or anal tone testing did not predict the presence of cauda equina, did not correlate with findings on MRI scan for those who are CES positive. So the question needs to be, well, why are we doing this test? Next, please, Rob. Thanks. In terms of other physical examination, light touch sensation, what we would normally do would be light touch sensation and pinprick sensation around the perianal and in perianal region into the saddle region. So the paper on the right, the paper by Michelle Angus and her team up at Salford, they looked at around 308 patients, tested their perianal sensation, and found that there wasn't significant difference between groups for those with radiologically confirmed cauda equina and those without. They found similar findings with the anal tone testing. And we know from previous studies on the left there that the sensitivity of these tests is generally pretty poor. So again, it throws into question why we're doing some of these invasive and sensitive tests that are potentially unpleasant for the patient, potentially put the clinician at risk, particularly if you're a sole practitioner, and if they have a limited clinical value. More recently, over the last few years, residual bladder volume has been used. And there are some papers that are suggestive that this might be a useful measure, but it's not actually measuring cauda equina function. What it's measuring is what's left in your bladder. And there are a whole host of reasons why you might have residual bladder volume. And they may be pain related, they may be due to other pathologies, which we'll talk a little bit about later. But there's a paper by Venkasartan, next slide please Laura, which does suggest some residual bladder volumes post-voiding that may be useful as part of the picture of helping to diagnose cauda equina. And this might be part of the decision making about whether you're going to scan this patient or not with a query of cauda equina. So if a patient has more than 200 mils post-voiding, they found this to be sensitive and specific when relating to patients with positive cauda equina on their scan. So this may have some traction in terms of helping to manage the patient through the system. In and of itself, though, these patients will have, let's not forget, these patients will have presented with significant back pain. They will have subjectively had reported symptoms of cauda equina syndrome. So does this really add and change our clinical decision making? And I don't think we know that at the moment. In terms of the research, there's the research around cauda equina. There is a reasonable amount, but the quality of the research is not in most cases with big cohorts, understandably, because it's a rare condition and of varying quality. But these are some of the papers that suggest that urological dysfunction may be a predictor of outcome. I'm not going to talk into them in great detail just because of our time constraints, but you can chase these papers up. But we do know, or there is a general consensus that if people are in retention, then they generally have a poorer outcome. So if we go back to those 4 categories that Laura described, with cauda equina retention or cauda equina complete, both of those categories had people who were in retention. If we operate on those people, we get them to see a surgeon, their outcomes are going to be poor. So there's good consensus really that if we can treat these patients surgically when they're still continent, when they still have control of the bladder, then they're likely to have a much better outcome. And obviously that has a massive impact for them in terms of their quality of life. This Koenig paper in 2017 looked back over a 10-year period and talked about sensation being a loss of perianal and perineal sensation less strongly associated with a very poor outcome, decreased anal tone being associated with a poor outcome, although we put into that the caveat that it's a poor test, and that surgery in under 24 hours for those patients with urinary symptoms would lead to a better outcome. And back to Laura.
Yeah, thank you. So I'm just going to really highlight that medication can actually masquerade as cauda equina syndrome, which makes it really challenging again, because if you look at the medication that are up on here, these are all routinely prescribed for patients with back pain and radiculopathy. And as you can see, things like gabapentin and pregabalin, it can give you urinary incontinence. So you need to be mindful of that. It wouldn't necessarily change our kind of approach to sending these patients on to be investigated, but you may just want to know if they've had a change in a change in dosage that coincides with some of the symptoms. But it's, it is very difficult sometimes to understand whether it is true cauda equina syndrome or it's just something else that's masquerading. Not only medication can do that, there are a raft of other pathologies that can actually mimic cauda equina syndrome. And in fact, we back in 2017 when we did a presentation, we wanted to call our presentation 49 Shades of Grey, but we were told we couldn't do that. But essentially, what we have up here is 49 items on here that can masquerade as cauda equina syndrome, and you can see there's just a huge raft of this. If you think about things like UTI, it'll cause retention. The list is endless essentially. So there are things that you need to be mindful of, and what you want to know is, do these patients have any of these pre-existing issues that you need to consider when you're considering whether this is true cauda equina syndrome or not. Over to you, Chris.
I think the book I read was 50 Shades of Grey, Laura, but
that as well. Sorry.
Did you miss the last page?
Lucky me.
So, in terms of, and I think one of the things one of the reasons why there's so many people on this webinar is that people are concerned about the medico-legal aspects of cauda equina. So we're just going to spend a few slides talking through some of that. We know that it's a big problem, and we know that it's an increasing problem, and I think that would be the summary. But also, it's a concerning thing to be involved in. Both myself and Laura and Sue, we've all been involved in cases of cauda equina where we've been accused of negligence, and it's a stressful situation for us. And clearly, the fact that the patient's going through that, it's a life-changing experience for the patient. So what we want to try and do is to limit these number of cases, so we can help to educate both the clinician and the patient, so we all know what to look out for. So in terms of the weight of the litigation, the vast majority is against GPs, which is kind of what you'd expect because they're at the front end. So 92% of these cases in this medical defence union were against GPs. A lot of them were successfully defended, but the weight of litigation is against the front end, and that's been supported by other papers, which we'll talk about in a minute. But if we think about who's going to be in these frontline roles now, there's a big move towards first contact practitioners in musculoskeletal, and that could be a physiotherapist, an osteopath, could be an OT, could be a podiatrist, could be a paramedic, but it could be a non-GP. So we're going to be increasingly are increasingly in the front line. And it costs a lot of money, as it shows here. But those last two lines at the bottom there, £8 million paid out in this series here, and £4.5 million went to the claimant's solicitors. So just bear that in mind. This study by Taylor in 2016 looked at 150 claims, and as I said, a big chunk of this went to the solicitors. So there is a big interest from the legal community to be involved with this condition. The NHS-LA is the NHS Litigation Authority, which is now called NHS Resolution. In 2016, they looked at 293 claims. They found that 70% of these were for people between 31 and 50. So again, it's one of the things that's a little bit different about cauda equina in terms of serious pathology. It affects mostly younger people. And if we think about the devastating consequences for a 31-year-old to be made incontinent, loss of sexual function, have to be manually evacuating their bowels for the rest of their life, that's a significant life impact. Next slide, please, Laura. Thanks. Further data, there's plenty here, and various different resources. The Medical Protection Society and NICE looked at 105 claims. Again, the vast majority in primary care, this time 80%. So we're looking at 80% up to 90% of these cases being at the front end. Fairbank's paper in 2014 looked at average compensation of around 336,000, and that's significantly changed. Next slide, Laura, please. The costs here, this again is a slightly older paper, but if we look at the cauda equina, there's 268,000 in 2012. Thanks, Laura. Thanks. This more up-to-date paper, the GIRF study. GIRF is getting it right first time. This was a report on spinal services in the UK, excuse me, which was published this time last year. And they reported £29 million being spent on Cauda equina litigation. And as Laura alluded to at the start of this webinar, it's the most litigious condition in orthopaedics. So 23% of all legal cases in spinal surgery relate to Cauda equina. They also picked up just this little detail that most referrals to specialist centres were made out of hours. So 3/4 of cases of patients with Cauda equina are dealt with out of hours or through the night. And there must be a way that we can manage that better. The GIRF report looked at the payouts, and those payouts have pretty much doubled over the last 4 years. So again, there's a significant cost implication for service providers in terms of their health insurance and their indemnity insurance against these conditions. Studies have looked at patients who've been through litigation, and they came up with various comments about their care, but also in a review of litigation cases, these were things that came up. And what they found was people weren't asked, or it wasn't noted that people had been asked about their bladder function, even though they might have had suspected signs and symptoms of Cauda equina. Timings of the contacts with patients weren't recorded, which made it difficult to say what the timeline was, who they had spoken to, how long it had taken in between seeing each practitioner, which is important. There was a failure to examine patients properly or act on significant red flags or refer on in a timely manner. And most of the litigation is either against GPs for either failing to diagnose or consider Cauda equina as a possible differential diagnosis, or a failure to move these patients on quickly. And that's what we need to do better. And if people do suspect it, or if it's been in their differential diagnosis and they consider that the patient doesn't have Cauda equina, there's not been evidence in the documentation that patients have been safety netted. Thanks, Laura. So what should we do? Well, on the back of that, we should definitely have some good notes. That's an absolute minimum. So in your notes, you need to record the history in detail, record your findings, both positive and negative. Really important, because we want to know whether that patient's changed. If they go on to develop symptoms, we want to know when that change happened. You need to examine the patient carefully. Now, we'll talk a little bit about the examination in a bit. Use cue cards or information cards to give to the patient so you can safety net them, so they understand exactly what symptoms they should look out for. Make sure you refer on within your local pathway in a timely manner. And if you're working in isolation, if you're working in a practice, if you're not linked into the networks, then it's really important that you understand what your pathway is for these Cauda equina patients. Now, that might be to refer through to A&E, but it might well be worth having that documented as a protocol. So from a legal perspective, you're very clear, but two, from a legal perspective, it's very clear what your usual practice would be. And then you need to follow these patients up. You've got a duty of care to manage these patients. So just sending them off to A&E may be the start of that journey, but a lot of these patients do bounce back out of A&E. So there's a requirement on you really to follow those patients to make sure they're getting appropriate care. These are some resources that Sue and her team developed, and the one on the left, the larger, the one with a picture on of the patient, is a information sheet that Sue and her team give to the patient in clinic to let the patient read through what the signs and symptoms are, and she's found that very useful. And the one on the right is a cue card, and it's a business card sized information sheet that contains the signs and symptoms of Cauda equina, and the red box on the side there tells the patient what to do if they develop any of those signs and symptoms. And the language used on here was developed out of a qualitative piece of work that Sue did with some patients, which I'll talk about in a minute. Just to say that these cards are available now in 31 languages. I think we're just about to add our 32nd language, which is going to be Thai. At any time now, and they're available for free through these resources, so through the MACP website and through the MSK service in, I think, Peterborough, who've done most of the translation. In terms of what we do with these patients once we've seen them, well, we talked about those patients who move on, should they have early surgery or not. This Cleaver McFarlane paper is a seminal paper that's certainly worth a read, that talks about the benefit or otherwise of early surgery to patients with complete retention, the CECR category, and those with the incomplete. And it shows that there was no benefit from early surgery for those patients who'd already gone into retention. This is Sue's study that I talked about earlier. They interviewed patients who'd had Cauda equina syndrome to talk to them about their whole experience, their journey, and what that meant to them in terms of their life experience. And they came up with 7 themes. These themes were the massive amount of pain, the impact on their life, sense of change of seriousness. These patients, this pain was like something they hadn't had before. It was much more serious, okay? And they recognised it as being different to the usual pain. But every patient she spoke to had had contact with health professionals, significant contact with health professionals through their journey. So they could all have been, or their outcome could all have been different. And that's the difficult thing. A lot of these patients have gone through and developed significant symptoms further on. They'd moved down that track from suspected Cauda equina into retention and complete, by which time it was too late to change their outcome. And they suggested these aids to early diagnosis. If I'd only known, then that would have been helpful. I've put Janine's story up here at the top of the slide. So Janine was a patient I spoke to, who is one of the medical secretaries where I work. So I won't go into big detail about her story now, but if you want to know about her story, then link into the podcast that we did on the MACP website, and I think Sue's going to make those resources available. So that's, again, freely available, but she's very candid about her story, and so it's certainly worth a listen, and it keeps you focused on what's important. There are some other resources here. This is some stuff we've been involved in, but there's a whole host of other stuff out there. And this was a consensus day we had in December, where it was a multidisciplinary consensus day with neurosurgeons, spinal surgeons, chiropractors, osteopaths, patients, legal representatives, and physiotherapists. So we pulled this together on the back of the Connect white paper to say, well, what should be included and what shouldn't be included. And what came out of this was there was a consensus, absolutely, that anal tone testing shouldn't be done in primary care. And that will be part of the recommendations of the National Low Back Pain Pathway at the end of March. But the subtle sensation testing should be done. And some of those timelines that I alluded to earlier, in terms of the 4 weeks of symptoms not needing same-day scanning, will also be included. So I think I would point you towards the National Low Back Pain Pathway Clinical Network group and Brit Spine coming up at the end of March to see that paper being produced. And that should change national guidelines, which I think is going to be helpful.
So I'm just going to round up very quickly a few of the papers that are out there in the domain, really, just to highlight some of these issues. And the first one is from Nicholas Todd, who is a neurosurgeon and a prolific writer around Cauda equina syndrome. And he has developed what he describes the Cauda scale. And I think what we really want to get across is that you need to have some caution around using this scale. So it's based on the 3 areas of the bladder, sensation, and anal tone, and really talks very much about the objective symptoms of these patients. And what he suggests is that those patients who have subjective signs but no objective signs would not require an MRI scan but should be warned. And of course, you know, that doesn't sit very comfortably with us at all, because we know subjectively that's more useful for us, whereas the objective signs are really not very reliable, as Chris has already told you that. He also states that pain is the most common reason for bladder difficulty, and patients can be discharged without, and just warning them to look out for signs and symptoms. But again, so you need to be fairly cautious in using this scale. It certainly needs a bit more work around that. So the second paper we just want to highlight is this is currently underway. So this is a study that's looking at aiming to identify and describe the presentation and management of patients with Cauda equina syndrome within the UK. And it's going to be the largest prospective study. And what it'll do is it will establish the incidence of Cauda equina syndrome, current investigations and management practices, and look at the adherence to national standards of care. And those outcomes will be stratified by clinical presentation and patient management. So it's one that's going to look pretty exciting, I think. ENTICE, which is the evaluation of the national treatment and investigation of Cauda equina syndrome. So this has looked at the adherence to guidance really around Cauda equina syndrome and that pathway. And what it states is that patients with suspected Cauda equina should undergo an emergency MRI, which should be carried out by the receiving hospital prior to referral to a specialist unit. And then surgery should be performed at the earliest opportunity. But unfortunately, what this study shows is that spinal units, and Chris also talked about this, are being used as an out-of-hours scanning service because of the lack of provision in DGHs, so general hospitals. So most patients were referred out of hours, and many were transferred for an MRI without subsequently really needing surgery. And what it shows is that we could be reducing the number of referrals to these spinal services by 72%, which is pretty high, and reduce the number of patients that are transferred by 79%. So it's significant that we haven't really got the pathways right. But it also showed that those who were scanned prior to referral did experience longer waits and delays to MRI and decompression, which quite significantly. So if that MRI was done at the spinal unit, it would take less than a day, whereas if it was done locally, it was taking over a day. So there are some things that really need to be tightened up with regards to that. Finally, just the last couple of minutes I think I've got, is just want to talk very briefly about a study that myself, Chris and Sue are involved in. And basically this is looking at developing an international framework for clinicians who are faced with serious pathology, of which obviously Cauda equina is one of those. And along with that, we're looking at malignancy, fracture and infection. And what we know is that the evidence around the use of red flags in identifying serious pathology is really challenging, and it's confusing for clinicians. So what we've done is really taken the current evidence that is out there, and then we've sought expert opinion to come up with some kind of consensus around what that should look like in terms of which red flags for which pathology. And then what we've done is we've added context around those items. And what we're doing is we're going to provide a framework which will help guide those clinicians in asking the right questions, and with strong clinical reasoning, really come up with the right decisions around how to deal with those patients who might possibly have a serious pathology. So we're currently at phase 4, so it's currently out for peer review, which is imminently coming back. And then what we'll do is we'll create the final framework. It's looking pretty exciting, and we're hoping to launch that in June or July of this year. So watch out for that. It'll be coming soon. So, and that really finishes our presentation. I just want to highlight that that international framework has been funded by many people along the way. So we're very grateful for that funding. So they're represented by all of these here. So that really brings us to the end of our presentation. So thank you very much for listening to us, and we're open to some questions.
Yep, so I can see there's some questions already appeared in the Q&A box, which Laura and Chris will answer, but if you've got any more, please pop them in there so that we can try and answer as many as possible.
Okay, so I'll start at the top. So Yuande has asked, said, thanks for hosting the webinar. Is there any way to prevent Cauda equina syndrome? Firstly, and are there any factors to consider in post-surgery rehabilitation? So I think that in terms of can we prevent discs from bulging or metastatic disease from compressing the Cauda equina? No, we can't. But what we can do is recognise the symptoms early, and I think that's the key thing, and that will be the take home from myself and Laura, is that these symptoms need to be identified early. They're identified predominantly in the subjective examination, and the patients need to be moved through the pathway in a timely manner in order to prevent them having the life-changing consequences. I don't know if you want to add anything to that, Laura.
No, I would absolutely agree with that, Chris. Yeah.
Great, thank you. Katie's asked about whether patients, when they get to A&E, is the outcome normally positive? I'm guessing by positive, Katie, what you're saying is, do these patients end up being scanned and having surgery? Well, the answer is definitely not.
No.
And I think that will be a general experience that people have had. The challenge then for us, well, that's down to two reasons. One is about understanding. So often people at in A&E are focusing on the objective signs, the physical tests, subjective. So there's a journey we need to go on with our A&E colleagues to continue that discussion, which was your second question, Katie. So I think that's ongoing work, but I think the low back pain guidelines coming out in March will be helpful in terms of changing practice. The challenge for us as clinicians is what do we do with those patients who get bounced back from A&E? How do we manage those patients? Because you might send them to A&E with a concern about Cauda equina. The patient then rings you up and says, well, they just sent me away and said told me not to worry about it. But if the patient still has symptoms or indeed signs of Cauda equina compression, what do you do with them then? Because the duty of care is now back in your court, and you have to manage that. So that's a challenging situation, because that means you chase up those patients, you need to pick up the phone again, you need to talk to somebody else, and you need to push that patient through the pathway. We can't accept that we let those patients go, and that's really difficult. That's where I find that really challenging and frustrating. And we have the patient's best interest at heart, and actually, I think we're in a good position to manage those patients and to identify those patients. But if they come up against somebody with a different opinion or less understanding of Cauda equina, then that can be a challenge.
Yeah, and I would just add to that, Chris. I think it is really challenging when that patient is knocked back, and one of the things that we have to trust the system to some extent. This is our pathway, so therefore, if your pathway is to send the patient to have an emergency MRI at that hospital, then you've got to accept that they will have done something to exclude Cauda equina syndrome. And I would agree with Chris. I said, when they get bounced back, you have to make a decision. Do you bounce them back in, or are you satisfied that you feel that they've been examined enough to warrant you then perhaps doing an urgent MRI scan which is probably more in your gift than an emergency. So yeah, absolutely challenging.
Mohammed's asked about what to do for radiculopathy if it's been around for more than 12 weeks. It depends, I think, is the answer. If it's improving, then that's fine. If it's not, then you might want to consider further investigation. I think that would be the simplest answer. Anonymous attendee, is there an accepted radiological definition of Cauda equina, i.e., for example, 50% occlusion? There have been papers that look at the amount of occlusion and try and link that in with the clinical presentation. But what those papers have shown is that the degree of occlusion doesn't correlate with the presentation of symptoms. So we can't use just the radiological definition or radiological appearance on MRI scan to say someone's got Cauda equina syndrome. It's a syndrome which is a collection of symptoms. So it's symptom-based, backed up by the radiology. And a good example of that would be somebody with spinal stenosis. You may have severe spinal stenosis, but no overt presentation of Cauda equina.
Yeah, and I would agree. And I think, I've had patients who I've scanned because they've got a radiculopathy, not because of Cauda equina syndrome, but they've come back with, Cauda equina compression. but no symptoms. So actually, you know, we're going to get the converse of that as well, really.
Yep. Lizzie, I hope we've answered your question around A&E bouncing. Joanne, would you ever suspect Cauda equina if a patient only had back pain? In and of itself, probably not. If that was really the only thing, unless their pain was significantly escalating, it's a possibility, but it would be very low down on my differential diagnosis. Doesn't mean I wouldn't scan them, because I might scan them because I might be more suspicious of one of the other more serious spinal pathologies, but so something like infection or metastatic disease, for example.
Which probably raises the issue around, you know, who do you warn about Cauda equina syndrome? And I think, you know, that's important too, because I wouldn't warn everybody about Cauda equina syndrome, and the back pains with back pain alone, I wouldn't always warn them either. So I think, you know, you have to pick your patients on who you're actually going to warn around Cauda equina syndrome. Would you agree with that, Chris?
Yeah, absolutely. And it links into one of the other questions from Anonymous. What exactly should be included in safety netting to avoid over panicking a patient, or would you just give the cards and information to them? I think what we need to be is absolutely clear with the patient, and the evidence from using these cards has not been that patients panic or it overburdens the system. The cards are written in layman's terms. They're very, very clear. It's very clear about what the patient should be looking out for, and patients have used them to link into the pathways. So I think the information that's on the Cauda equina cards and the sheet it's a good example. It's not the only. You can design your own, but I think it needs to be clear. It needs to be written in a language that patients understand, in terms of level, but also, you know, with the Cauda equina cards, a language specifically. I had an email this morning from somebody saying, or on Twitter yesterday, saying, thank you for the Kurdish version because it's helped me to manage this patient. So, you know, we get really real life examples. So I think it's just about being clear.
Yeah, and it's about context, you know, making sure that the patient absolutely understands the context of it. You know, I will often say to my patients, you know, this is very rare, but it can happen, you know, and it's all about that communication and being able to frame it in a way that they understand it.
Yeah. And those cards are all available on the MACP website, so, and they're free to download from there. Thatcham Natural Therapies has asked a good question. They're asking about, will writing letters help reduce bounce back from A&E? Yes. There is a move towards having pro formas that talk through your concerns, your physical and subjective criteria for suspecting Cauda equina. So yes, I think that will be a sensible thing to do and a sensible thing to have as part of your pathway. So yes is the short answer. So
with our service, we tend to write a letter, but we also ring A&E to tell them to expect this patient, and that might be to speak to the on-call orthopaedic team, but essentially we'll make an effort to actually ring them to warn them that they're on their way.
Another question: in the periannual sensation has poor validity and sensitivity. Why are we moving to test it? So what we presented was the evidence that's there at the moment, but there is some emerging evidence coming from Michelle Angus and her team. I'm not sure it's been published yet, but in some work they've been doing that has suggested that sensation testing may be a good predictor of those people that go on to develop Cauda equina compression. So that's why it's likely to stay in for the moment. But you know, obviously we'd change recommendations as the evidence emerges.
Yeah.
Let's have a look. Sarah's asked, we frequently see older patients with spinal stenosis and prostate issues. This is often challenging to differentiate between this and Cauda equina. If it's a sudden onset and change, I guess my index of suspicion is raised, but any other tips for clarifying and differentiating the two conditions? From the kind of broader medical point of view, you know, we need to be asking questions around, if we're talking specifically about prostate issues, then symptoms that relate to that. So we'd be asking about nocturia, how many times they get up in the night to pee, whether their urinary stream is slower, whether they have difficulty initiating, whether they have any terminal dribbling after going to the toilet, whether they have any erectile dysfunction. So all of those, and whether they had a PSA done recently. So all of those would, if you had an older patient, an older man or a man over 50, let's say, I'll put myself in that category, unfortunately. If you have a man over 50 with some urinary dysfunction, then you should be asking those prostate screening questions as really part of your normal examination, and that will help you with your differential diagnosis, I think. But as Laura alluded to in that 50 Shades of Grey slide, there are a whole host of reasons why people might have urinary dysfunction. It might be related to infection, in which case we'd need to be asking questions about, is it painful when they're passing urine? Has the urine changed colour? Has the frequency changed? Has it changed in smell? All those, is there any blood in the urine? All those additional kind of broader medical screening questions. Do you want to add in, Laura?
No, that's perfect, Chris.
Anusha has asked, will there be any significant changes to the existing national pathway being released at the end of March? I think, and this is in relation to you updating your local pathway, I think I would hang on and update your local pathway in line with the National Low Back Pain Clinical Network group recommendations that come out at the end of March, because I think that's going to be the way that they, there are discussions with NICE and NHS resolution about how that might come into international guidance. So I think that would be my recommendation.
Definitely.
Christine Comer, one of our co-authors. She did a brilliant paper on spinal stenosis. If you want to read anything about spinal stenosis and cauda equina, then that paper's in Journal of Musculoskeletal Science and Practice, and Christine writes brilliantly. So lessons to learn about cauda equina and spinal stenosis and how to write a brilliant paper. So Christine has asked, how would you manage a patient with cauda equina compromise found on MRI but no cauda equina symptoms? I would manage them by safety netting, Christine, and that would be my main way to manage them. Cauda equina syndrome, we're looking for people with symptoms, not just a radiological presentation. So I would note the MRI findings and then and safety net that patient and document it in their notes and go from there. Laura?
Yeah, well, that's what I said earlier. Really, we will find patients who have cauda equina compression but actually no symptoms, and I think we just have to safety net them, make sure they're aware. Yeah.
Nicole Pars asked, hello, for a patient who has MRI for radicular pain but normal neurology but denies any bladder or bowel saddle symptoms. If the MRI comes back with compression of the cauda equina, what is best practice? Do they require very clear safety netting or a neurosurgical review? It's a tricky one. If they have significant radicular pain that's worsening, and they have, or if they have radicular pain but normal neurology and nothing else, then you've got to make a decision about whether you want to manage that patient. You could manage that patient, do some watchful waiting. You could treat that patient, but clearly there is a risk that patient might then go on to develop symptoms. So you would certainly have to very clearly safety net, as you suggest. But if their pain's improving, if all the symptoms are improving, I would be inclined to hold on to them and watchfully wait. If their symptoms were deteriorating or not improving, then it would be a neurosurgical review from my perspective.
I would agree with that.
Similar question there. Just bear with me, folks. Should we all have some senior clinical support at our organisation who have special interest in cauda equina before we send to A&E? This is from Mohammed. Can it be shared as generic to all MSK services? I think this is really important in terms of your local pathway and your local governance structures. Depending on the grade that you are, there's always going to be, there should always be somebody around that can help you to manage that. So if you're a junior therapist or a junior member of staff, then your role is and your kind of duty of care for that patient is to escalate that to somebody with more experience to ask the question, because we know that cauda equina is a difficult condition to diagnose in the early stages. So your duty of care is to escalate that to somebody more senior, but that would need to be included in your local pathway. So and if you haven't got one, then that would be useful to kind of articulate, I think, in terms of, if you're junior, then that goes to the senior person to then make a decision about whether to refer on or whether that patient requires imaging.
I think it's really important just to have a network of people that you can talk to. I often ring Sue and Chris about patients, and will ask their opinion. I think it's just helpful to have those conversations, because sometimes whilst you're articulating that case, it can sometimes become quite clear what's required, I think.
There's one from Susan Robinson. It may be obvious, but what do you mean by safety netting? So in terms of safety netting, Susan, what we're saying is you're providing a safety net for the patient. So that safety net is around making sure that the patient understands what symptoms that they should look out for, what symptoms they should be concerned about, but also if they develop those symptoms, what they should do about it. So you need to very clearly, it's almost like plugging the patient into the pathway, so that they know that an urgent, if you say to them you need to urgently get to A&E, that urgent means same day. They need to understand that. So urgent for some people might be, well, I'll go in 2 days because that's urgent. That's what my GP urgent appointment is. But they need to be very clear about what they're doing, and that's a same day appointment. So it's just being absolutely crystal clear about what they should look out for and what they should do about it.
And also just recognise it, making sure they understand the risks and benefits of taking action. It needs to be very clear, if they don't do this, these are the likely consequences of what could happen. So it's about that patient making informed decisions about what happens next, essentially.
Brilliant. Thank you both very much. We've slightly run over, apologies. I know we've already lost 1 or 2 people who've had to go off to clinics, but thank you all for joining the webinar, and thank you very much to Laura and Chris for that very informative presentation. I just want to emphasize the Sue that has been referred to occasionally in this presentation is not me. Thank you everybody for joining, and you should all get a link to the recording when it's up online. So